Hello and welcome to Talking Africa, the podcast that gets behind the news from the continent. My name is Nick Norbrook. Welcome to the pod. How are you all bearing up? Have you had enough video calls yet? I hope you're all staying safe wherever you may be. All our coronavirus reporting is to be found on the africareport.com. News, analysis, scenarios. We have a map of the spread of the pandemic and calls to action by African leaders across politics and business. My guest this week is Bill Gates. The founder of Microsoft is pouring hundreds of millions of dollars into the fight against COVID-19. A big believer in data, he's also emerging as a champion of global institutions, something that we get into in this conversation. We also talk about approaches to the virus in Africa, investment in innovation, and much more. So without further ado, please enjoy this conversation with Bill Gates. Given that the predictions, including your own, were there about a pandemic, possibly of this nature, and myriad intelligence agencies worldwide had developed plans to address it, why were most governments so ill-prepared?
Well, it's tricky for governments to keep track of whether they're ready for things that are, improbable and don't come very often. In this case, we do see that places that had SARS had a plan in place where they said, okay, immediately get the PCR equipment focused and get the test kits so that we can do widespread testing and immediately do surveillance, not just of travelers, but, see if we have community widespread. So the playbook at this point, it's easier to say in retrospect, the playbook that allows a country to keep the cases low enough so that both the health and the economic impacts are very low. That's clear. We really have to look at two stages. One was, did we build up the tools and the plans in advance of this showing up? And that's where I'd say we did fall short. And that, the goal of my speaking out and others back in 2015 was that people would do what I call germ games. And they'd say, okay, who calls the testing people? Who makes sure the right people are tested? How do we get a surveillance effort going very quickly? And investments in those tools so that scaling testing is quick, getting antivirals is quick, and getting a vaccine is quick as well. Then you have, looking back at, once it was spreading in December and January, the speed of reaction there. At this point, the key focus, though, needs to be on where we go from here in terms of, making sure that we keep the caseload as low as possible, but also try and minimize the disruption, which in some cases is an economic effect. If you get into developing countries, it's even, food security becomes at risk if you're not careful about how you're dealing with the lockdown policies.
Do you think then that certain African countries were right to sort of copy-paste the social distancing measures that Asian, European, American countries have done, given the lack of social safety nets across the continent? And I think we're already seeing hunger riots in certain South African cities, for example.
Well, I agree that figuring out how this works in a developing country is an unsolved problem. The developing countries don't have the large resources that the developed countries have. So I'm certainly not criticizing them for their lack of preparation. But the idea that you can't just do what you do in rich countries, because in rich countries, the number of people it requires to get food out, and the physical spacing is far easier, and you have a formal economy where you understand how to get checks out to people. So the challenge for developing countries is immensely more difficult. Even things like, should you keep doing measles vaccination campaigns? That's an example where the foundation has expertise, and we're concerned that by getting rid of those, the cost is greater than the benefit. So we are in uncharted territory of how a developing country can reduce the rate of infection of this respiratory disease without threatening other health or food or basic requirements that people have. This is not going to be easy. The good news is that at least as far as we can tell, the total number of cases in Africa are not gigantic. Now, eventually we'll understand, is that because people aren't coming forward to be tested? Is it the limitations on testing capacity? Are we benefiting from the weather? Certainly the age structure, should be beneficial, that there's far less old people. But I have to say, of all the things I don't understand about the epidemic, the status in developing countries is, the most unclear to me. I get up every morning and I click on the Johns Hopkins South Africa data, Nigeria data, India data, trying to understand where we are in developing countries.
Speaking to a former chief of staff to Ellen Johnson Sirleaf in Liberia, who was there during the Ebola outbreak, he said that a health crisis quickly becomes a governance crisis. Now, you and others say that testing and tracing is going to be critical to bring this virus under control, but that does require a certain level of bureaucracy, which I guess means a tough choice for many African countries. If they don't have that capacity, do they stick with the social distancing and risk the hunger riots? Or do they open up and risk infections spiking and high mortality rates? Is there a way of not choosing either of those options?
The test that would be ideal for developing countries would be one that you can simply swab your nose by yourself, put the swab in a piece of liquid, and then pour that liquid on a piece of paper. This is the rapid diagnostic test, which many people in Africa know, because you take blood for a malaria rapid diagnostic test and you get that line that says you are or aren't infected with malaria. We are doing our best to scale up that kind of test and get it available at very low cost and in very high volume. So that would avoid you having to go to a location, which of course isn't always going to be easy to do. And, under lockdown rules, can you actually get to that testing site or have somebody send you a kit? If your sample has to go back to a central machine, which is typically a PCR machine, that's going to be hard to scale up. Of our early grants going back to February for this disease, helping get the diagnostic capacity going in Africa was a top priority, to get the PCR machines that are there, to have the right kits so that at least you'd have a sense population-wide of what's going on. We worked with WHO Afro, we worked with African Union CDC. To some degree, Africa does, we're taking a lot of the workers who do polio eradication work, and, which is, a donor-funded thing. And those skills, those people are now, shifting most of their attention to this COVID epidemic and trying to help out. So that capacity is there, but it's going to be difficult. The ideal would be that in the rural areas, the rates of exposures are low and that you don't have a huge problem. So, certainly things like the farming hopefully won't be interrupted. The big challenge is the urban the urban slum areas, where you don't have a reliable way of just delivering food to people in most cases.
I've just been speaking to a winning team in an MIT hackathon who are sort of trying to do exactly that sort of lo-fi approach to communicating with urban slum populations. They're trying to piggyback on brewers and distribution systems of Coca-Cola, etc. You yourself have been arguing for a flotilla, an armada of innovators to tackle COVID-19. What are the promising approaches apart from the holy grail of a vaccine? And do you think there are sort of, I don't know what to call it, lean innovation or sort of lo-fi things which could be cheap and easy to take up across the continent?
Well, certainly when you're getting a lot of people with symptoms, the idea of building a facility that's separate from healthcare where COVID patients can go and get the isolation and get the oxygen treatment. For most people, oxygen is enough. It's going to be very difficult to scale up ventilator capacity. Of course, even in the rich world, the people who go on the ventilator, once you get to that stage, their survival is fairly low. But being able to provide basic oxygen, and there's a lot of innovators looking at how to make those systems, very, very cheap, and how you help get, a facility that would hold those patients, in a way that they're quarantined, which is harder to do in the household area. I think it's great that innovators, everybody are working on these things. Our foundation's very involved in getting these new testing innovations done. We're also looking at all the different drugs that might help. And in terms of something that would make a big difference by this summer, I would say, the biggest hope is that one of these drugs is highly effective and that it's something that is cheap enough and that we can manufacture at large scale, and it doesn't require a health worker like an IV infusion, rather that it's something you can take orally. I think although it doesn't look like hydroxychloroquine is going to have a big benefit, people did get excited because, that's an oral drug that there's a lot of capacity to make. So we need to find something that can be scaled. We're trying enough different things that I'm hopeful that a few of them out of the hundreds that will be tried by sometime in the summer, we'll be getting those not just to the developed countries, but to the developing countries as well.
You give a sort of a 9 months to 2 years estimated lag before a large-scale global vaccine might be rolled out. How would it get to African countries? What sort of mechanisms? Would it be the Gavi scheme?
Yeah, the procurement will raise supplemental money for Gavi from the rich country donors that support Gavi, and Gavi will understand how to, working with its partners WHO and UNICEF, how to get countries to adopt a vaccine and how to get the vaccine out. This would obviously be a campaign vaccine, so it would be like we do with meningitis A or we do with measles. And meningitis A is the most similar because that was done for all age groups in the so-called meningitis belt. This would be a vaccine that would be for all age groups. There might be some lower cutoff, but here we would be including adults, which most campaigns like measles, you don't include adults. Typically, polio's under 5, measles is usually the same way. So it's going to be large numbers that you go into the country and, try to get very high coverage so that even when coronavirus comes back, that you have so many people that are immune that it's not possible to have another widespread epidemic.
And now there's a quote from that 2015 talk of yours that I'm sure lots of journalists are throwing back at you these days, where you say, you don't have an exact budget for what this, the global health system, or, the the diagnostics, the creation of vaccinations, the army of